points by scanning the QR code that will be displayed at the end of this presentation. So without further ado, let me introduce today's first speaker, Dr. Paul Mitchell, who will be speaking on the overview of small cell lung cancer landscape, the Australian experience. Dr. Mitchell is a medical oncologist at the Olivia Newton-John Cancer Centre and Wellness Centre at Austin Health in Melbourne. And he's also an associate professor at the University of Melbourne. He was the president of the Australasian Lung Cancer Trials Group, and he is also the chairman of the Thoracic Alliance for Cancer Trials. And and one very interesting thing that he mentioned to me earlier is that for all the Singapore webinar participants, his wife is Singaporean and he's very, very familiar with Singapore. So without further ado, Dr. Mitchell.
Thank you very much for the opportunity and invitation to speak. Thank you to Specialised Therapeutics. We're focusing on treatment of small cell lung cancer. These are my disclosures. Small cell, as you know, is a very nasty disease, and the outcomes for patients are generally around the world, less than 5% will be alive at 5 years. It varies a bit from country to country, but in the more developed sort of world, then small cell comprises between 10 and 15% of all lung cancer cases. In general, it has been associated with heavy tobacco smoking. One of the problems with small cell is that around 2/3 of patients present with extensive stage disease where there are already widespread metastases, and also brain metastases are very common in this disease. The treatment really, up until this point, really for the last 20 years at least, has been based on platinum etoposide chemotherapy in limited stage disease, potentially curable platinum-based chemotherapy, platinum etoposide 4 cycles, with concurrent thoracic radiotherapy has been shown to improve survival, and prophylactic cranial radiation also improves survival, also in that group of patients. In extensive stage, platinum etoposide chemotherapy to 4 cycles has been really the standard of care. The role of prophylactic cranial radiation in extensive stage remains somewhat unclear. We have some trials for and against, but it is possible to treat with prophylactic cranial radiation, but we would generally just monitor the patients. Thoracic radiotherapy, which is trials have been generally sequential thoracic radiotherapy, have also shown some modest benefit. Now, the big change now has been the advent of immunotherapy. And the first important phase 3 trial in the extensive stage setting is the IMpower133 trial. The design is shown there. It was first reported a number of years ago now. Basically, it was standard of care platinum-based chemotherapy with placebo or with atezolizumab, and atezolizumab was continued until progression of disease or loss of clinical benefit. And the usual sort of criteria that you might expect, including patients with treated or asymptomatic brain metastases. And these are the patient characteristics. You can see around 200 patients in each arm. Around half of patients were aged 65 or above, much the same in the 2 arms. Performance status, about 2/3 were performance status 1, 1/3 performance status 0, much the same in the 2 arms. A small proportion of patients, less than 10%, had brain metastases and liver metastases, which is generally seen as a poor prognostic factor, or around 30 to 40%. These are the results of the study. At the bottom there, progression-free survival, overall survival at the top. See, with progression-free survival, the atezolizumab group are running at the top on the blue curve there, and the although there's very modest change in median progression-free survival, the hazard ratio was actually 0.77. And if we turn to the overall survival, we can see that overall survival benefit here for the atezolizumab treated group with improvement in 12-month survival from 38% up to about 52%. And here we have a hazard ratio of 0.7. This is the forest plot for these groups here of subgroups. We see that brain metastases patients, it was not entirely clear whether there was a benefit there or not, but a relatively small proportion of patients having brain metastases. The younger patients, for some reason, not such a clear benefit as in the older patients, but it's possibly some anomaly, just in scattering anomaly in the data. In terms of the adverse events, atezolizumab plus platinum-based chemotherapy, the overall profile there of adverse events was much the same as placebo plus chemotherapy. When we turn to immune-related adverse events, first of all, the immune-related adverse event rate was fairly low, but it was clearly higher in the immunotherapy-treated group. Particular rash there. Rash was more common, both grade 1, 2 and 3, 4, as compared to chemotherapy alone. And a small but probably definite increase in incidence of grade 3, 4 hepatitis, infusion reactions, colitis, but generally well tolerated. Following on a fairly short time afterwards, a similarly designed trial where we looked at particularly durvalumab in the same setting. This is the Caspian trial. Similar eligibility criteria. Again, asymptomatic or treated stable brain metastases. And here we had platinum-based chemotherapy, or the addition to that of durvalumab. There was also an arm including tremelimumab as well as durvalumab, and the primary endpoints are shown there. I might mention that in both the I33 trial and the Caspian trial, it was optional to give prophylactic cranial radiation, so it was not allowed to give thoracic radiotherapy. So this is the durvalumab plus chemotherapy versus chemotherapy, the updated overall survival curve. We can see that, first of all, the hazard ratio is fairly similar to what we're seeing in the IMPOWER 133, similar range, IMPOWER being 0.7, here 0.75. And we can see also, as in the IMPOWER, that the tick curves are sort of separating after the sort of 6 to 9 month mark. The tremelimumab addition arms, so durvalumab plus tremelimumab is in the light blue running along here, possibly doing a little bit better over here, but overall not significantly different from chemotherapy. There were two other trials that were reported around the same time. This was a phase 2 randomized trial from ECOG using nivolumab. It was one-sided stats and phase 2 randomized. So we looked at chemotherapy versus chemotherapy plus nivolumab. And generally, we saw much the same as we had with durvalumab and atezolizumab, hazard ratio there of 0.67. And this is the immunotherapy combined group running at the top. The Keynote 604 study was essentially the same design, again, in terms of looking at pembrolizumab in this setting. Stable brain metastases allowed, stratification factors shown there. Progression-free survival, hazard ratio 0.75, so fairly similar to the other studies. The overall survival at 0.8 wasn't quite as good as the other studies, and in fact, because this study had been designed with a number of looks at the data, multiple analysis points, it required to have 0.0128 and it did not reach that significance level. So essentially you might call borderline significance, but under borderline. And there's a quick summary basically of the 4 trials that have been done in the extensive stage and that have reported Empower 133 and Caspian, clearly positive studies. Certainly in Australia, we have Empower 133 as a regimen is funded. To date, the durvalumab regimen hasn't been funded, but I think there are other issues other than the efficacy, which is really very similar. And Keynote was just not quite so good and didn't actually reach significance. Also, some earlier data, Checkmate 451, looking at a maintenance strategy of immunotherapy. And there we looked at nivolumab versus placebo, and also nivolumab plus ipilimumab, and neither of these studies was positive. There was perhaps a small slight benefit for the addition of the immunotherapy, but very, very modest effect. One of the problems too in small cell is that we do not have clear predictive factors for these patients. It's not clear around the role of PD-L1 expression or TMB, and we do need better ability to identify which patients are going to do well and which ones aren't. Now, just as an aside, extensive stage small cell looking at thoracic radiotherapy. This is from a systematic review looking at the addition of thoracic radiotherapy in extensive stage. And the main trial is this trial from Slotman, hazard ratio of 0.84, and overall an effect, but a fairly modest effect in terms of improvement in survival. If we look at thoracic progression as the first site of progression, though, it's very, very clear that radiotherapy will have some impact there. And this has led to a trial which we've just opened. This is the Trans-Tasman Radiation Oncology Group in conjunction with the Thoracic Toga, the newly named Thoracic Oncology Group of Australasia, covering Australia and New Zealand. And this is a phase 2 trial looking at the addition of thoracic radiotherapy concurrently, essentially with the Caspian regimen of durvalumab plus chemotherapy. And the endpoints here are feasibility and toxicity. We're just using a modest dose of radiotherapy, 30 gray and 10 fractions, with the idea of a number of similar studies happening around the globe and that potentially feeding into a phase 3 international effort. Now, in terms of limited stage small cell, we're still really awaiting convincing data with immunotherapy in this space. The Stimuli trial run by ETOP and the French group and our Australian New Zealand group joined in towards the end of the study, looked at a consolidation approach with nivolumab and ipilimumab, and that did not achieve its endpoint. And we can see that the studies, basically durvalumab-based studies, atezolizumab and also pembrolizumab-based studies are ongoing. We are doing the pembrolizumab-based study currently, but we have found that during COVID that we're seeing very, very few limited stage small cell. That's just about all extensive stage. In terms of the second line options and beyond, there's the old cyclophosphamide, adriamycin, vincristine regimen called VAC, or we call it OCA. And topotecan phase 3 trial was done many, many years ago, which was no different in efficacy, but there was some reduction in toxicity. Topotecan has never really been widely used in Australia, so we mostly use the cyclophosphamide, adriamycin, vincristine. But we will also use in relapsed patients irinotecan and probably personally more in, say, third line treatment. We might use paclitaxel if the and if they're not particularly good performance status, we might use a weekly type regimen. So by and large, though, we see poor efficacy in patients who fail on treatment or just after completion of chemotherapy, and we certainly need more effective regimens. So in conclusion, we've got clear efficacy data now for the addition of concurrent and consolidation checkpoint inhibitor therapy in extensive stage small cell. That's particularly with atezolizumab and with durvalumab. And to date, the consolidation only approaches in extensive stage, and for that matter in limited stage as well, have not been successful in terms of the addition of checkpoint inhibitors. It's unclear too whether there's going to be long-term survivors with this sort of approach in extensive stage small cell. And we are hoping that the addition of concurrent thoracic radiotherapy may achieve a higher proportion of long-term survivors in that group, hence the interest in the RTOG, the Translational Radiation Oncology Group study. The limited stage studies really are awaiting the results. We need more clear biomarkers for which patients will benefit from small cell, and certainly some more effective drugs. Now, just to end the presentation, I'd like to present some data on the use of Lurbinectedin in Australia, Zepzelca access program, and these patients were treated under an access program. There were 62 patients as of August this year that were on the program. You can see that there's an age range up to 83. Around half of patients male. If you looked at this 20 years ago, just about all of the patients would be male. So small cell has become relatively more common in females. 3/4 of the patients performance status 1, and a relatively small group of patients with worse performance status. CNS metastases in about 1/3 of patients, and half with liver metastases. These were generally extensive stage patients. The number of prior therapies, 60% had one prior therapy only, so treated in the second line, and then 1/4 of patients treated in the third line setting. And we can see that there's a group of patients who relapsed early, 15 patients, 24% of patients relapsing early. About half of patients staying on treatment, or rather the chemotherapy-free interval greater than 3 months. So it's about half of patients there. And again, about 1/4 of patients having overall a chemotherapy-free interval less than 90 days. Looking at that in terms of the duration of that patients stayed on treatment, so we haven't actually analysed for response yet. We can see there's a group of patients that have been only on for a fairly short period of time, and then there's other groups of patients where you might expect that they must be benefiting from the treatment because they're staying on for 6 to 12 months. And just one thing we had looked at in terms of the patients in the therapy-free interval, short chemotherapy-free interval, we could see that generally more of these patients, about twice as many patients as were in the short duration treatment. In other words, they relapsed early on lurbinectedin, and as compared with, for example, the patients who are on longer period of time. So the early patients who had only treated shortly after the cessation of chemotherapy didn't do so well. Thank you very much.
Thank you, Dr. Michelle, for the excellent talk. So thank you for summarizing the first-line treatment landscape in extensive stage small cell lung cancer. If you have any questions, please leave them in the chat section, and we will discuss them at the end during the panel discussion. We will now move on to our second talk on systemic therapy options following first-line treatment of small cell lung cancer by Dr. Santiago Pons. Dr. Pons is a medical oncologist in charge of the thoracic tumor unit of Hospital 12 of Octubre. I'm not sure whether I'm pronouncing that right. For the last 10 years, he's been involved in clinical research, especially dedicated to small cell lung cancer and targeted therapies development. Similarly, he developed the molecular profile program of lung cancer at the molecular tumor board at the same hospital. He has contributed to numerous peer-reviewed publications, and he's also the scientific coordinator of the OncoServe Foundation, dedicated to the promotion of medical education and independent clinical research. Currently, he's working at the Institut Gustave Roussy in France in the Department of Therapeutic Innovation and Early Trials. Over to you, Dr. Pons.
Hello, thank you for the kind introduction. It's a pleasure to be here with you in this meeting, talking about a disease that I love, that is small cell lung cancer, and talking about post-progression therapy options that will be a challenge right now. This is my disclosures. Actually, we already know that small cell lung cancer is a very high response rate disease to chemotherapy. And for the last 30 years, the standard of care, it's been platinum etoposide chemotherapy, plus or minus prophylactic or cranial irradiation. We know from that the response rate is around 50% or 70% of the patient that we treat, and the overall survival is around 8 to 10 months. Right now, this is already changing because we have now the new standard of care for small cell lung cancer, extensive disease with chemoimmune therapy, with the Caspian trial and the Empower trial testing durvalumab and atezolizumab, and improving for the first time ever overall survival for those patients. Saying that, we are not we are not curing any patient, so we need actually second-line treatment and further treatment for this disease. To our mind is coming the first option that we have for those patients, that is rechallenge of platinum chemotherapy. From many times we are discussing which is the definition of sensitivity to platinum, more than 90 days or less. Maybe right now the standard approach to say that a patient is platinum eligible or resistant. And one of the options that we have was the topotecan as a established second line versus rechallenge for platinum for those patients with a relapse for more than 90 days. We have this trial actually comparing topotecan versus carboplatin plus etoposide. We have like 80 patients treated in each arm. These are the clinical characteristics of the patient. And we have the result for median progression-free survival being better for a combination of chemotherapy, 4.7 months versus 2.7 months, with a hazard ratio of 0.57. And also for median overall survival, no changes. Median overall survival for both 7.5 months with a hazard ratio of 1. So for many patients that we don't have any other alternative, regarding some of the we are going to discuss later, probably platinum rechallenge in platinum sensible patient may be an option for those patients. From the point of view of toxicity, it's feasible to do carboplatin plus etoposide again. We already know that topotecan, one of the major issues with topotecan is actually the toxicity profile, and is, as I say, feasible to do that. For immune therapy in second line, we have some data, not very encouraging data, but we have some of them. We have this trial for pembrolizumab in second-line small cell lung cancer, progression to standard of care. And we have that for PD-L1 patient, PD-L1 positive patient, we have a response rate of 35% of them, with a few of them with complete and partial response, and disease control and a high disease control rate of 43%. Those data are less good with PD-L1 negative patient, and also we have a gain in progression-free survival and overall survival with PD-L1 positive patient treated with pembrolizumab after standard of care. We have also this French trial with atezolizumab that we have been testing the role of immune therapy as monotherapy in second line. And we have advantage of progression-free survival, but mainly overall survival advantage when we treat a patient with atezolizumab versus chemotherapy, if those patients are again a PD-L1 positive, IC1, 2, or 3, versus a PD-L1 negative patient, in the same way that we are checking with the pembrolizumab trial. For second line, also we have some data with those patients harboring a TMB high. We've been having many experience with the CheckMate 032, checking nivolumab plus EP in patients with small cell lung cancer. Those patients with a high TMB will have a better response rate, both with nivo and EP-nivo. Regarding overall survival, those patients receiving EP-nivo with a high mutational burden, we have an advantage in overall survival for those patients. May represent, we don't have this access in Europe, but may represent in a patient with a high TMB an option EP-nivo to treat the small cell lung cancer. We have also this trial present with immune therapy plus anti-angiogenic therapy. It's a Chinese trial, canrethilumab plus apatinib. And again, we have a gain for those patients receiving canrethilumab plus apatinib, again in overall survival. Having another proof that immune therapy and keeping immune therapy probably after chemoimmunotherapy first line may be an option for some of the patients. Regarding some biomarker selection, we have the history of Notch. The DDL3 expression is quite high in small cell lung cancer. We know that many of the patients will have overexpression of the Notch pathway. I did my thesis on this, and it's quite frequent. We have this drug, the Robatid drug, that if you remember at the beginning, long time ago, near 5 years ago, we have a very good response rate for this drug with DDL3 positive patient, near 30% of the patient having objective response. The overall survival was encouraging in between those patients without DDL3 expression and DDL3 expression, but unfortunately, the toxicity profile and the median overall survival for this trial was actually negative, with a median overall survival of 6 months and with a high toxicity rate, with a discontinuation rate of 5% due to AEs, grade 3 or plus, more than 40% of the patient having this kind of toxicity, mainly thrombocytopenia, photosensitivity, anemia, fatigue, and pleural effusion. So right now, this drug is no longer in development. But regarding Notch, because it's a very good target for small cell lung cancer, regarding Notch, we have new alternative for treatment. We have this tarlatamab. This is a monoclonal antibody, B-specific monoclonal antibody targeting DDL3 and targeting CD3 in the cell of the small cell lung cancer in the T cell. And we have two mainly action of this drug. the lysis of the small cell lung cancer itself by binding this monoclonal antibody, and also the T cell activation. And not only the T cell activation, only the tracking of the T cell that are active to the core of the disease. We have this phase 1 that is really well tolerated only with some cytokine release syndrome at the beginning of the infusion. We are learning about how to infuse this monoclonal antibody, and we do inpatient for 24 hours with a high hydratation, and only grade 3, one patient with no related death to this clinical cytokine release syndrome, and some other toxicities that make the drug feasible, and mainly for patients with a lot background of treatment. Many of them receiving chemoimmunotherapy as first line, lurbinectedin, combo with lurbinectedin, treated thereafter with AMG 757. We have a partial response. We have a stable disease and a disease control rate ranging about 30% of the patient. So with a very tough population, we have a very nice activity for this drug. Actually, for patients with a confirmed partial response, 30 patients, the median duration of the response was near to 9 months. The median time to response is around 2 months, and we don't have enough maturity of the trial to say something else, but I think we think that can be a new option in the future for those patients. Regarding more biomarker selection, we have many small cohorts and trial, but I think that one of the emerging and important target in the small cell lung cancer is going to be the DDR, the genes related to the reparation of the DNA. We have several trials testing PARP inhibitors plus immunotherapy plus chemotherapy, different aptitudes. I have some experience with the Nirado and Ariane trials that is checking immunotherapy plus PARP inhibitor for those patients. We don't have still data on activity, but it's important maybe to do personalized medicine for those patients and checking this status. We are coming to lurbinectedin, that actually I think is one of the main issues that we have in small cell lung cancer. You know that lurbinectedin is an inhibitor of the transcription factors. Also, lurbinectedin, we have some immune activity with induction of the cell proliferation, inducing interleukin 6 and interleukin 8. We have an inhibition of the immune response activation checkpoints. And also we have induction of angiogenesis that we were checking in the Chinese trial, that the angiogenesis maybe is playing a role in small cell lung cancer. We have this phase basket trial with lurbinectedin with small cell lung cancer that was published in Lancet Oncology last year, with a dose of lurbinectedin 3.2 milligram per meter square, that we have for the progression-free survival with a median progression-free survival of 4.1 months, and for overall survival around 1 year for those patients. The response rate is quite encouraging for monotherapy. You can see the first plot here with a huge 67% of the patient having partial response, stable disease also, and clinical benefit ranging for more than half of the patient. The disease control rate, around 73% of the patient having a control of the disease when we treat with monotherapy with lurbinectedin. As I say, PFS around 4 months and overall survival around 1 year for second line treatment for those patients. The adverse event profile for lurbinectedin is well known. It's mainly hematological. is mainly anemia, thrombocytopenia, and neutropenia. It's easy to manage in monotherapy that, and probably we have to do an effort to keep the doses of lurbinectedin, maybe also using factors, because we know that the exposure to lurbinectedin is directly related to the response rate. So it would be better to keep a good dose of lurbinectedin in that case. We have this Atlantis trial comparing lurbinectedin plus doxorubicin versus CAF, adriamycin, cyclophosphamide, vincristine, or topotecan. That is not positive for overall survival. These are the data that we are going to publish soon. We don't have any advantage except for probably the toxicity, and we are probably doing new trials to check in a phase 3 manner the effect of lurbinectedin alone over the small cell lung cancer. We have some other approach. This is the Resilient trial. This is a trial, a phase 1 trial, also checking irinotecan pegylated, checking 2 doses of this 85 and 70 milligram per meter square. We have some preliminary data that are going to be published also in a paper in a few weeks. The response rate is also very encouraging. Partial response around 43% of the patients, stable disease 26%, and objective response rate in total quite encouraging, and more important, benefit for this treatment, 72% of the patient harboring some kind of activity for Naliri, that is the irinotecan pegylated. This is an example from our center with a liver disease with a very good activity of this drug. Regarding toxicity, as with lurbinectedin, the main toxicity is hematological toxicity, mainly neutropenia in the day 8 of the liposomal irinotecan. But to my knowledge, also is a very good toxicity profile and may represent a new option for those patients in the future. Median PFS 3.9 months, and median overall survival in this phase 1, 8 months. Please don't post this result because they are not already published. We have also another idea of combination of irinotecan that for sure is a good option, plus lurbinectedin. And we published this phase 1 trial, multi-cohort trial, but with a lot of patients with small cell lung cancer, 21 patients, checking the efficacy of lurbinectedin, in that case 2 milligrams per meter squared, that was the research dose, plus irinotecan 75 milligrams per meter squared, plus GCCF. As I said, it's important to keep the doses of lurbinectedin. And we have that for all the patients, the overall response rate is 72% of the patient. Clinical benefit, partial response, plus a stable disease, 81% of the patient. Disease control rate, near 90% of the patient. Median duration of the response, 6 months, and median PFS around 6 months. It's very encouraging, the data that we have for patients with refractory disease also. This is a very tough population. We have only 8 patients, but with an overall response rate of 50%. So it's quite good from my point of view, and probably one of the best options for those patients with refractory platinum disease. From the point of view of toxicity, is adding toxicity from the hematological point of view. That is the reason that we are treating with a primary prophylaxis of factors. Some other lab abnormalities, like liver abnormalities, but really no death related to the treatment, and feasible to do this approach. This is in a beautiful manner, the waterfall of the response of those patients with a partial response and stable disease closing to 86% of the patient. Importantly, if we look for those patients with a good response or bad response at the beginning, we have activity for both of them with a combination of Lurbi plus irinotecan. And we're going to finish with a trial that we published last week. Actually, it's a phase 1 trial also, combining atezolizumab plus lurbinectedin. Lurbinectedin in a escalation manner, 2.5 plus atezolizumab fixed dose, and then the monotherapy doses, 3.2 milligram per meter square plus atezolizumab at the fixed dose. The primary objective of this trial in the phase 1 is the research to research a dose for combining atezo plus lurbinectedin, and the final dose that we have is 3.2 milligram per meter square. And secondary objectives is response rate and progression-free survival. This is the characteristic of the patient. We only have here second-line patient. In that case, we only have here patient immune naive, but the trial is going to have a phase 2 part with more than 150 patients, including immune previously treated patients. This is the toxicity profile. Actually, hematological toxicity is remarkable, again, like in every lurbinectedin trial. And actually, the recommended dose is 3.2 milligram per meter square plus primary prophylaxis of factors due to this toxicity and to avoid decreasing the doses of lurbinectedin. Regarding the activity, we are quite happy because we have 7.7% of the patient with complete response, partial response 50% of the patients, stable disease 26.9% of the patient, disease control rate of 84% of the patient. Actually, this is really, really encouraging for us. PFS is not mature. We have a PFS of dose level 1 with 7 months, and with the dose level 2, that is the 3.2 milligram for lurbinectedin, is not yet mature. We have 4.4 months for this. This is the waterfall of the patient with different levels, with 2.5, 3.2, and 3.2 plus primary prophylaxis. As you see, we have a lot of patients with good response, complete response also, and those patients responding with a very long duration of the response. So probably we are going to have more data for this combination for second line, pure second line, and we are going to have also, is going to start a trial with the strategy of maintenance, platinum plus immune therapy first line, and then starting a therapy for maintenance with lurbinectedin plus atezolizumab following this schema. As a take-home message from my point of view, it's clear that chemoimmune therapy is the standard of care for first line. In the second line, we have a variability of alternatives. We have the challenge of platinum, but sure that lurbinectedin has a very good activity in the second line alone or second line in combination. And from my point of view, lurbinectedin is the standard second line right now for our patients. Irinotecan pegylated or in combination with lurbinectedin emerge as a potential alternative, mainly the combination with lurbinectedin for those patients having a platinum refractory disease, and current approaches combining immune therapy and chemotherapy and different strategies like a target therapy, like the Notch B-specific antibody may improve the outcome of our patients. Thank you so much. These are my email from my 2 institutions. Thank you so much.
Thank you for the excellent overview of second-line small cell lung cancer treatment, Dr. Pons, and it's truly encouraging to know that there are many new treatments in the pipelines. So hopefully our patients would have better treatment options in the future. If you have any questions, we'll take the questions again at the end. So the third and final talk for today is by my friend and fellow colleague, Dr. Amit Jain. He will provide an overview on the treatment landscape and the challenges faced in treating small cell lung cancer in Singapore. Dr. Amit Jain is a senior consultant, medical oncologist at National Cancer Centre, Singapore. He has just completed his PhD and his research interest is in the field of cancer immunology, and he is currently exploring the use of cell therapies for cancer. So without further ado, over to you, Amit.
Thank you for the kind introduction, Dr. Tanuja. My name is Amit. I work at National Cancer Centre, colleagues with Dr. Tanuja. And today, over the next couple of minutes, I'm going to try and summarize the key challenges that the medical oncologist faces in clinic with all the data that we now have available for the treatment of this challenging disease, small cell lung cancer. I would like to just go through a few paradigms in the treatment of extensive small cell lung cancer that we face as medical oncologists in the clinic. The standard of care is based on clinical demonstration of efficacy rather than a mechanistic understanding of the disease. Most of the first-line therapies that we use work in a majority of patients, and unfortunately, the development of resistance is almost universal. This is a cancer which appears to have a lack of actionable biomarkers. Even though loss of RB and P53 proteins are common, these are actually rather difficult to target. Enthusiasm for ongoing development of clinical strategies is moderated by a historical failure in actually improving the lethality of this disease. In Singapore, approximately 10 to 15% of lung cancers are small cell lung cancer, accounting for about 150 to 200 new cases a year. This is a cancer that is largely a medical pandemic. It can be attributed to smoking-related carcinogens. The cancer is an aggressive cancer with a short doubling time of 25 to 30 days, and this means that without treatment, typically patients may only survive weeks. With treatment, survival is still dismal. Overall survival at 5 years is generally quoted to be less than 7%, and this is not different in Singapore. The lethality of this cancer, unfortunately, has not changed in the last 4 decades, despite this being one of the most extensively tested cancers in both the preclinical and clinical settings. Amongst newly diagnosed small cell lung cancers, 60 to 70% of patients with newly diagnosed disease have extensive stage disease that is incurable. As I mentioned earlier, this disease has not been able to be genomically and immune categorized in terms of lending clinical insights into subpopulations that have differing susceptibility. Nevertheless, we continue to be enthusiastic with what may come in the future, and currently there are more than 270 active or recruiting clinical trials registered on clinicaltrials.gov. And this represents a rapid trial and error approach to apply novel agents to this disease. There continues to be an unmet need for agents that can traverse the brain, and this is particularly important because amongst all the cancer patients, amongst all the small cell lung cancer patients we see, up to 10% of them may present with brain metastases, and unfortunately up to 40% of them may experience brain metastases in their lifetime. So I'm going to quickly summarize chemotherapy use in the first and second line. 4 to 6 cycles of platinum doublet therapy is well established in the first line. Generally, one would choose carboplatin if there's any issues with whether patients can tolerate cisplatin. The platinum agent of choice may be combined with etoposide or irinotecan, depending on which part of the world one practices in. The majority of patients, unfortunately, will still experience relapse within the first year of treatment. There are several labels that may be clinically useful. If relapse occurs during treatment, we might call this platinum refractory disease. And if it happens within 90 days of completing treatment, we can call this platinum resistant disease. And if it happens after 90 days, then we can call this platinum sensitive disease. This is relevant for patients who might be eligible for re-challenge with first line. In the setting of platinum sensitivity, re-challenge is preferable. In the second line setting, topotecan remains the only formally approved treatment option, and this was derived from a clinical trial comparing topotecan against best supportive care, which gave an overall survival of 26 a median overall survival of 26 months in the topotecan arm as compared to 14 months in the arm with their supportive care. Nevertheless, the response rates are modest at best, between 10 to 20%. There are multiple agents that have been tested in the first and second line setting, and these have been done in earlier phase clinical trials and therefore are included in the NCCN compendium of active agents that can be used against this disease. Briefly, the use of immune checkpoint inhibition in the first line has been defined now by the use of atezolizumab and durvalumab in combination with platinum doublet therapy, as the speakers before me have mentioned. It is important, though, to understand that this is in the context of other trials that have not given a clear signal of activity, and at least one trial that has been described as, has read out negative for the addition of immune checkpoint inhibition. Beyond the use of immune checkpoint along with platinum doublet, atezolizumab and durvalumab also can be used as maintenance. And so this is currently the state of the art for the use of IO as maintenance or in second line setting. There are some negative trials again that are worth highlighting. However, in the context of several earlier phase trials that have shown some benefits in the second line setting onwards, several immune checkpoints are also included in the NCCN guidelines. And so as a rehash, I'll just put out the NCCN guidelines. And here you can see that the first line treatment is defined by platinum doublet therapy. This can be, the platinum drug is either in the form of carboplatin or cisplatin, combined with either etoposide or irinotecan, and given along with an immune checkpoint inhibitor, which can be either atezolizumab or durvalumab. In the second line setting onwards, there are now two preferred regimens, either use of topotecan or now lurbinectedin. And there are multiple other agents that have been tested in early phase trials, in phase 2 setting largely, which can be used both available as IV and oral agents, as well as immune checkpoint inhibitors, pembrolizumab and nivolumab. A few key points to highlight in what we currently understand about how lurbinectedin may play a role in a patient's life. This drug is now approved for use as a single agent on the back of a clinical trial, a phase 2 study, which showed an overall response rate of 35% amongst 105 patients, with a median duration response of about 5 months, with cytopenias being the main side effects. And this was given in the setting of patients who had received platinum-based chemotherapy in the first-line setting. In a phase 3 clinical trial called Atlantis, lurbinectedin was combined with doxorubicin and compared against CAV or CA plus topotecan. While it missed its primary endpoint, it demonstrated tolerability and overall activity in patients. One previous speaker has talked about the combination of irinotecan and lurbinectedin, and this combination will progress into further stage, advanced stage clinical trials and appears to be promising thus far. 3 early phase ongoing trials that combine immunotherapy with lurbinectedin will be informative for how we can combine immune checkpoint inhibition with lurbinectedin in the setting of patients who have received first-line treatment. Beyond these drugs that we've mentioned, there are other treatments that are on the horizon, and there are some challenges with some of what has already been tested. While I mentioned earlier the loss of p53, RB1 proteins, and the amplification of MYC is very common in small cell lung cancer, these pathways continue to be extremely challenging to target. There are multiple novel agents that include PARP inhibitors, alkylating agents, VEGF inhibitors, and aurora kinase inhibitors that are currently being tested in both phase 1 and phase 2 setting. A brief mention is worthwhile for the first targeted therapy, that was developed for small cell lung cancer. DLL3 initially appeared to be a promising target for small cell lung cancer, and the drug rovalpituzumab tesirine, an antibody drug conjugate, was tested with promising results in phase 1 study. However, in phase 2 study, with low rates of response and due to toxicity, it appears that the product has now been withdrawn from further testing. So looking to the future, what we hope additional clinical trials will give us insights into are the optimal sequencing of platinum doublet, IO, lurbinectedin, single agent chemotherapy, and how we can combine these drugs best and do that in the context of patients with varying degrees of platinum sensitivity in order to improve the lifespans of our patients with extensive stage small cell lung cancer. I'll briefly go through a case study before I end. Here I'll describe one of my patients in clinic. This 66-year-old gentleman who was diagnosed with extensive stage small cell lung cancer in July 2018 with liver metastasis was treated with good response with 6 cycles of platinum doublet therapy. And in view of his good response, we considered him for consolidation radiation to the thorax as something that we hoped would improve his outcomes. After discussion at a multidisciplinary tumor board, we made the decision to proceed with consolidation radiation, and he received 36 grays in 12 fractions in February 2019. Subsequently, and unfortunately, he developed pneumonitis, which appeared to have elements of both interstitial pneumonitis, as some of the areas that were involved appeared to be outside of the radiation field, and there certainly seemed to be an element of radiation pneumonitis as well. We treated this with steroids, as well as steroid-sparing agents, and in consultation with respiratory doctors. He had good disease control for 18 months and had some control over his pneumonitis, but thereafter had slow progression of his disease. In view of his poor function, as well as his preference for an oral form of treatment, I offered him temozolomide. He had an initial partial response, but subsequently progressed within 2 months. Thereafter, the patient was offered best supportive care with home hospice support and deteriorated gradually, passing away in May 2021. With the current set of approvals that are now available for small cell lung cancer, there are an increasing number of options that might be available. And for patients like this, that one might be extremely nervous to give any form of immune checkpoint inhibition to, a patient like this may be suitable for single agent chemotherapy or newer agents such as lurbinectedin. So with that, I'll wrap up my talk. Thank you very much.
Thanks, Amit, for the excellent presentation. So we have now come to our panel discussion. I'm sure all of you have lots of questions to ask. So feel free to type your questions into the chat box. We have a couple of questions already. So I'll start with the first question that is directed to Dr. Mitchell. How does the 3-year OS data from Caspian influence the long-term efficacy perception of IO plus chemo in first-line extensive stage small cell lung cancer?
Yes, well, the curves are staying separate, so that's looking good. But I think if you look at the data as a package across the different immunotherapies, I'm not convinced that we're going to see the sort of 5-year survivals that effect that we're seeing in non-small cell lung cancer. So the addition of concurrent and the maintenance immunotherapy certainly adds an important component to small cell treatment now. But, well, I might be proved wrong, but I think that we're going to have to do better than what we're doing at the moment to really substantially lift those 5-year survivals.
Uh, thanks for that. Maybe I can just chip in and ask, you mentioned that we are not seeing the 5-year survival curves of like with immunotherapy as what we see in the non-small cell lung cancer setting. And we always say that smokers have immunologically hot the tumor, and they usually tend to respond to immune checkpoint inhibitors. Why is it that unlike the non-small cell lung cancer patients, our small cell lung cancer patients don't seem to respond as well to immune checkpoint inhibitors? Any idea?
So is that for me to answer? Yes.
Yeah, you can go ahead, and then we can go around the room as well.
I'll put in my bit. I mean, it's not entirely clear the relationship with PD-L1 and TMB for that matter. I mean, there are some data now coming through about different subtypes of small cell, and there is a particular inflamed subtype associated with immune-related gene upregulation. That may be part of the story. I mean, it is a very difficult area to look into in small cell, with the nature of the genetic landscape being mostly loss of gene effect, and it's difficult to interrogate. But I think we probably are on the cusp now of getting some really useful information over the next few years, particularly coming from the immune therapy trials.
Amit, anything to add? Amit is our immunology expert. I saw Doc. One of you can go first, whichever.
No, go, please.
I think it's been very challenging to find any treatments that have dramatically altered the treatment landscape of small cell lung cancer. We've always made modest improvements. It might well be that this is a highly mutated cancer with some level of immunogenicity, but manages to preserve itself as an immune desert. And there's a fair amount of work that's ongoing to try and understand how small cell lung cancer makes itself an immune privileged cancer. This might be one avenue of work in the future to try and understand how to alter the tumor microenvironment. And that might be one way I hope in track immunotherapy for small cell lung cancer.
Dr. Pons?
Yes, so regarding the two questions that you were asking, firstly, about the Caspian trial, that is the only one that we have 3 years follow-up. Probably from the Empower, we are not going to have any longer follow-up. And probably I agree with Dr. Mitchell that we are not going to catch the same amount of benefit than from non-small cell lung cancer. But probably I truly believe that having some experience in the long term from the NIVO and IPI-NIVO trials, especially the Checkmate 32, that actually I had a lot of patients, like more than 50 patients treated with this schema. And at the end of the day, we have like 5% of the patients being long-term survivals. Probably this is linked to a different biological subgroup that we don't still know. If you look to the curves at 3 years, probably we will have some kind of 5% of patients being long-term survival at 5 years, maybe. The question is, and that is jumping to the another question, why in this, from the very first time, a good disease for immune PD-L1, smoking, a lot of high mutational burden maybe, but it's true that we don't have a lot of PD-L1 expression. It's quite less than non-small cell lung cancer. There is different cohorts, but around 15-20% of them expressing that, and moreover, a lot of infiltration, but of Tregs. This infiltration of Tregs is actually, to my point of view, clinical, I'm a clinician point of view, changing the landscape in small cell lung cancer. And that is because why I think it's not enough only PD-L1 inhibition to keep this benefit. If you look to the PFS curves and the duration of response in the Caspian and in the Empower trial, first line, and comparing even with a squamous, that in a squamous first line, we are only doing maintenance with immune therapy. It's quite similar, the both curves, and it's like we don't have the same amount of benefit that in the keynote non-squamous that we are giving Pembro plus pemetrexed. And somehow we are changing the landscape, and I think it's going to be very important for the future. Maybe a maintenance strategy with PD-1 inhibition plus something else. That from the Lurbinectedin plus Atiso is going to be a trial that is going to start within the next months as switch maintenance. And maybe this is the way I agree with Dr. Mitchell and Dr. Jain that probably we have to do something else better in that way.
Thank you all. So we've got another question to Dr. Pons. Why do you think the Atlantis trial failed?
Good question. I think that one of the main issues is the dose of lurbinectedin. We are pretty sure, and we have data right now from the phase 1 that we did with lurbinectedin plus Atiso. If we decrease the dose of lurbinectedin, it's slightly affecting the efficacy of lurbinectedin. So it's quite different using one dose or another. And keeping the dose intensity of lurbinectedin is crucial to get the benefit of that drug. So I think this is the reason, combining with Toxo, that the dose intensity of lurbinectedin is not being so good as in monotherapy. That is the real reason of not having a benefit from that trial. That is the reason I truly believe that lurbinectedin is still a very good option in monotherapy at 3.2 milligrams per meter square, keeping that dose in the models that is already published, and then we will publish from Atiso lurbinectedin trial. If we keep that dose, it's quite enough, and probably is the reason because Atlantis failed.
Okay, can I just ask a follow-up question on that? So in your practice, what do you use as second-line treatment for the platinum refractory patients? Do you use a single agent lurbinectedin, or do you do like combination of lurbinectedin plus irinotecan?
For those patients, I think that to my experience, we don't have a lot of patients, but the data coming from the phase 1 irinotecan plus lurbinectedin seems that for this tough population is quite good enough, I think, to go for this. No?
So you would do the single agent?
No, I would do combination.
Combination.
Irinotecan plus lurbinectedin.
But earlier you mentioned this, you were concerned about the dose reduction, right? Because with the lurbinectedin, is that something that you find is going to be a problem with the irinotecan combination as well?
No, because we have a synergy between irinotecan and lurbinectedin. It's not the issue. It's not the same issue that with doxorubicin, and it's not the issue with atezolizumab, because we have kind of synergies. So this is the reason I think we have this good data. One thing that I did once in my clinical practice was combining liposomal irinotecan that is available in Europe for pancreatic cancer plus lurbinectedin, because I think toxicity, hematological toxicity, is decreasing with liposomal formulation of irinotecan, and also data of liposomal irinotecan is super good. No, I have this experience also.
Okay, so this is something we can look forward to. We've got another question. Maybe I can take this. Is lurbinectedin approved by HSA for use in Singapore? Yes, for our Singapore audience, lurbinectedin is approved by HSA. It was approved in September this year, and in fact, if anyone wants to know, we had the Singapore experience with lurbinectedin. We had about 13 patients, and they were very heavily pre-treated treated patients. So they were not really your typical second line patients as you see in the trial. So some of them were the third line, some of them were fourth line. And out of the 13 patients, 8 patients had the combination lurbinectedin plus irinotecan. And generally what we found from the physicians who used it, they found that lurbinectedin was easy to use. And generally what we had, the progression-free survival was about 4 months or so, and that is for that 13 patients that we had as part of our compassionate access program. Yeah, we've got another question for Dr. Pons. Is the current trial with lurbinectedin plus atezolizumab first-line maintenance enough for US approval of lurbinectedin in second-line of small cell lung cancer? Or will it be necessary to launch a new phase 3 trial with lurbinectedin to get the full approval?
No, actually, the advice of the FDA was to do this maintenance trial with immune therapy and to don't stop the indication in second line because of the data of the basket trial and this issue of the doses. Because of the Atlantis is not working, but we really believe that it's a matter of doses. It's not well designed, the trial actually. It's going to be enough with the maintenance trial and also the 2 small trials. The trial that I presented in second line in combination with immune therapy actually is in the landscape of keeping the approval by the FDA right now for second line and for a future for this trial.
Okay. Amit, you go ahead.
So, Dr. Santiago, it's wonderful hearing your insights on this. You're in the thick of it. You're planning new trials. What are you going to put your money on if you want to build your phase 3 trial? What's your combination of choice? There's so many ways to do this now.
Yeah. So if you had to pick one.
Phase 3, you mean for second line or for first line?
Second line.
Well, actually, I think that the second line. I'm not probably.
If you have to choose one, we're having a gun to your head.
I have a bias probably, but with the experience that we have from the phase 1 atezo plus lurbinectedin, having a very small number of patients, but having this control of the disease, and it's quite important that it's purely second line, because many times for small cell lung cancer we are doing kind of patient selection if we allow to enroll second or further line, because all those patients being further line is a different small cell lung cancer. It's a small cell lung cancer that is alive. So those data from Lurbi atezo is coming only for pure second line, only one line of platinum-based schema. No matter it was platinum plus radiotherapy.
Would the patients have had atezolizumab in the first line already?
Yeah, in the phase 2, we have 2 different cohorts, previously exposed to immune therapy and non-exposed to immune therapy. Each cohort with 80 patients.
Okay. And
so I will bet for immune plus chemotherapy.
Oh, plus.
Yeah.
Okay.
No, thank you for that. I mean, it's a slightly difficult question, to say the least. But it's very exciting to see early data.
Yeah, if we want to go further, I don't know, maybe a crazy idea to combine MAG 757, that actually is a very good drug, and is changing the inflammation landscape of its immune cell, because it's a B-specific, and probably combining this B-specific with lurbinectedin can be a nice idea, actually.
And I'm just going to ask a quick question. You mentioned this thing about PD-L1 and in small cell lung cancer. Do you routinely test for that in your patients?
Yeah, we did, and we are now doing, because it's a procedure in our hospital. But I did also in a very big cohort, in a Spanish big cohort of more than 500 patients, small cell lung cancer, testing in our population PD-L1, because you know there are some series from China and some other series giving us a very high expression of PD-L1, but it's not our case, and we have less than 15% of patients being PD-L1 positive in this Caucasian cohort of small cell lung cancer.
And on that same note, right? Do you rebiopsy, or do you routinely rebiopsy your patients who progress on first line or second line for that matter? You do?
Yes, normally yes. Looking after probably genes of the reparation of the DNA alteration to enroll those patients in trials, not from in a standard way for patient to be treated with any drug in second, third, fourth line, but searching those kind of alterations to to have some chance to enroll in PARP inhibitor plus immune therapy trials.
Okay, we've got a question for Dr. Mitchell as well. How important is the maintenance IO in first line small cell lung cancer?
Okay, I'll answer that in a minute. I'll just add to the previous conversation there. We looked at, we have a TMA of small cells, about 160 or 70 cases. And by and large, we were seeing a lot of PD-L1 expression in the immune infiltrate and very little in the tumor cells. Seems to be the sort of usual pattern. We weren't able to specifically relate that to the outcomes for those patients because the outcome data wasn't good enough. But I think that's a common observation. The question about maintenance IO, just if you put it around the other way, I think generally if you're using maintenance only, that's not a proven approach in small cell yet. The trials have been negative, including the Stimuli trial. And I certainly wouldn't be doing trials where I was looking at it only in maintenance or only concurrent. It just doesn't make any sense. We've got the data from the extensive stage patients where there is a clear benefit. And so somebody might want to test that sometime in terms of just giving 3 or 4 months of immunotherapy without the maintenance. But I think that's probably likely to be fairly ineffective. The other thing is that the curves separate at sort of after about 5-6 months around there. So it's hard to see where you're getting a substantial effect early on, but I think probably the concurrence sort of sets up the environment for the later benefit.
Okay, and to follow on with that, let's say, for example, if you have a patient who, let's say extensive stage small cell lung cancer and had just had etoposide carboplatin as first line and they progress without any immune checkpoint inhibitor, or a similar situation where limited stage lung cancer had concurrent chemo RT and progressed within 3 months and haven't seen immune checkpoint inhibitors and they are platinum refractory. So what will be your choice for second line therapy? Would you consider using your immune checkpoint inhibitors in the second line, or would you still go back to your standard second line chemotherapy options?
Yeah, I mean, it's attractive to try it, but the reality is that the trials have been negative. And so if you're going to try that, maybe it's in the context of something novel, a novel combination or something. Of course, second, third
like the lurbinectedin and the atezolizumab.
Clinical trials, so it's a difficult population to really get good results, and often they're only surviving for a few months. So very, very difficult area. I think that really we're probably going to make more inroads into perhaps dual immunotherapy type approaches with some of the newer approaches that are starting to look a bit interesting in non-small cell. And I'd like to certainly see a limited stage small cell, though, as I say, I think in Australia, the proportion of limited stage is normally about 1/3, and I think at the moment for us it's probably less than 10%. due to the late presentation, I think. But anyway, I think the 2 out of 3 of the existing ongoing limited stage do have concurrent and maintenance, one of which is maintenance only. So my money would be on the concurrent plus maintenance as being the way to go.
Okay. Amit, we have a question for you as well. Why did you use temozolomide for the patient that you mentioned in the case study? Why not another chemotherapy regimen?
Sorry, what was that? Oh, sorry.
No, this is regarding the case report that I just presented briefly, and in the second line setting, what I offered my patient was temozolomide. And so the question is, why did I choose this?
It's one of the options that is listed in NCCN, right? So why do you choose that?
Well, it might have been flavor of the season, and it was definitely directed by patient choice. He didn't want to be tied to hospital visits at this point in his life. He felt like he'd reached a point where he wanted the simplest possible treatment. He wanted something oral. He didn't want to be tied to chemotherapy suites. So then looking through the oral options, and there was some unequivocal spots in his brain. And so I was wondering about, whether I needed something that had some class effect for brain penetration. And those are some of the factors that went into choosing this. And of course, his tolerability, which proved to be okay. I didn't expect any response, but he did have a partial response. So that was pretty nice to see. I guess then the other thing at the back of my mind, thinking about small cell lung cancer and looking at what happens second line onwards, is always concern about how well we're getting into the brain, because so many patients will end up having CNS failure. So I thought I'd lead to another question and ask the panel here what they thought about how that's going to be addressed in the future.
Your question is, how is the brain penetrability of all the drugs going to be, is it?
Yes.
Okay. Dr. Santiago?
I have firstly one point for the temozolomide.
Okay.
Do you use it as well?
Not normally. It's I've been using sometimes, but it's not regular. But something that's quite interesting from temozolomide is if thereafter if you have a still patient after progressing to temozolomide or giving a courses of temozolomide, if you double check the tumor mutational burden, and the tumor mutational burden can change a lot. Actually, temozolomide can change the immune landscape in every single tumor, but also in small cell lung cancer. We have some cases of a small cell receiving temozolomide and the changing of the TMB, and then enrolling patients in immune therapy trials and having some nice responses because of that. So maybe it's not a full idea of giving temozolomide and thereafter checking if the landscape is changing as a comment. And to address the question of brain mets, I think it's really complicated. Actually, we decided to do the design of the Caspian trial, actually allowing brain mets untreated without radiotherapy, because I think brain mets is one of the issues that we have in small cell lung cancer. Actually, I don't know, maybe this strategy of the anti-angiogenic treatment that we mentioned in second line from this Chinese trial also, I don't know, maybe the angiogenesis can actually be better explored if we can improve the density of drugs within the brain using anti-angiogenic. We have this experience from some other cases in non-small cell lung cancer, so I think maybe that we may better.
And just to follow on with another question to Dr. Pons, do you have any data on the CNS activity of lurbinectedin?
No, not yet.
But just based on your clinical experience, what do you think? Do you think that it helps patients with brain mets?
Yeah, we don't have still with a measure that we can show, but yes, I have clinical experience of patients having brain mets and good control. But being honest, I can't give you right now data.
Okay. And to Dr. Mitchell, I think you mentioned the role, you were speaking a bit of consolidation radiotherapy in extensive stage small cell lung cancer. So there's the question to you. Do you often offer local therapy after response to etoposide platinum and plus immune checkpoint inhibitors? What do you think about the role of local radiotherapy in this case?
Yeah, so that really goes to the trial that we're running at the moment. I mean, there is some effect, as I indicated in my presentation, about therapy in limited extensive stage small cell, but I'm more interested in the potential benefit of mediastinal radiation in terms of trying to, I suppose, have some effect on the immune response against the cancer. Ultimately, yes, there's a local effect which is fairly modest, but I'd be more interested in whether adding radiotherapy might enhance the immune response.
In your trial, you're giving the radiotherapy concurrently with the chemotherapy, or after the initial?
I think
currently,
theoretically, I think that if you're going to try and use radiotherapy in this way, it should be concurrent.
Okay, and so far in your trial, do you find that very difficult for the patients to tolerate, or it's okay?
We've only just opened a week ago, so I can't tell you.
Okay, maybe down the road we'll hear some data from that. And we've got another question. What is the most promising biomarker in small cell lung cancer according to you? Maybe we'll just go around the room. Amit?
Well, if I was going to take a long view, I think if we look at how P53 and RB1 or MYC, I would pick MYC as something that is a difficult, but because it's so ubiquitous, but that's a dream target. And I think I'll let the other speakers pick the more relevant targets.
Dr. Mitchell?
I think the data on, I mean, it's only a small group, but inflamed group of tumours, I think we should try and work with, in the first instance anyway, to try and improve the therapies.
Dr.
I suppose the other thing from that too, with the Empower 150 regimen, non-small cell, whether their strategies like bevacizumab might have an effect there. It's possible.
Yeah, I agree. No, it's a tough field, but I agree with Dr. Mitchell.
And let's say, I mean, maybe we can do this last question. Let's say if you were doing this, having this webinar 5 years down the road, do you think we will be still talking about overall survival being about slightly more than a year, or do you see things changing tremendously? What are your views? Maybe we'll start with Dr. Mitchell, and then we can go around the room. That's not very that's quite sad.
Tremendously is a very hard work for small cell lung cancer.
That's not very encouraging that we all quiet.
I would change that word.
I'd be confident we have some effects. We've made some more significant progress. I mean, the addition of immunotherapy is really the first major benefit for overall survival really since chemotherapy was used. So we shouldn't dismiss that, but I think it's probably a 10-year plan rather than a 5-year plan.
Okay, so if it's 10 years, do you think we would have doubled the overall survival? No? Amit is the optimist. No. Let's ask him.
No, taking into account the last 30 years that we have like more than 40 phase 3 trials failing, improving anything in small cell lung cancer, I'm saying that I'm positive, and I think that with the immune therapy and probably PD-L1 is the first in the room, but not only different smart strategies, combinations, and so on. I think we can expect. I don't know if maybe doubling, but I think we are in the good road to improve. No, moreover, because we are, and one of the points that you did mention is that we have to biopsy and rebiopsy patients, even with small cell lung cancer, because we are treating all of the patient of small cell lung cancer like the same disease, and we know already that it's not the same disease. So we have to start doing this. I know that this is a very difficult disease. Patients are normally in not very good conditions, but if we want to help those patients, we have to do this effort, to biopsy, and biopsy. If not, it's going to be very difficult to double these overall survival rates.
Okay, thank you all for the excellent discussion. I really learned a lot, and I really enjoyed myself. But I think it's time for us to wrap up. So with this, I will end our webinar here. So I'd like to thank all our speakers today. Thank you for the excellent presentations, and also like to thank Specialized Therapeutics for putting together this webinar for us and inviting myself here. So all of you, so have a great evening. And just before you leave, remember to scan the code at the end of the webinar. You can get your e-certificate, and for those who want your CME attendance, you can scan the barcode as well. So thank you all, and have a great evening.